Hello, my name is Melania Abaca, and I've been a nurse at the SFVA for a little bit over a decade. This is a literature review of best practice on wet to dry dressing, which is no longer the standard of care for all wounds management. This is a collaboration with Lauren Phillips from Wound Treatment Associates at SFVA and Lewis Erica NP at SFVA. The following are the learning objectives. By the end of this presentation, participants will be able to define non-selective mechanical debridement and explain its impact on wound healing, identify 4 critical concerns associated with the use of wet to dry dressing, describe 2 key conditions that support optimal wound healing, and list 3 alternative evidence-based dressings that help maintain a moist and balanced wound environment. We began with the premise that wet to dry dressing may not be appropriate for all wound types. The following question guided our literature review. What is the best available evidence regarding the effectiveness of wet saline moistened gauze dressing for healing of surgical and chronic wounds by secondary intention? Pardon me. As we examined multiple studies and articles, a clear pattern emerged. The treatment of wounds healing by secondary tension is often driven more by long-standing tradition than by current evidence-based practice. These observations highlighted a significant gap between research findings and clinical application. Before we continue, let's check our knowledge with a little question. The following is true about wet to dry dressing. Select one answer. It is appropriate only for mechanical debridement. Can cause pain and suffering to the patient when changed. Each dressing change and wound bed disturbance causes hypoxia, vasoconstriction, cooling, and destruction of viable tissue. Removal of the dry dressing from the wound disperses significant bacteria into the air, increasingly lowering the capability for infection control. And E, all of the above. If you answer E, all of the above, you're correct. And this naturally leads us to a critical question. Why are the majority of wounds still being treated with an outdated modality like wet to dry dressing? In the following slides, we're going to explore the underlying issues associated with moist gauze and wet dry therapy and examine why these practices persist despite advancement in wound care. Here are some facts about wet to dry dressing. It involves the application of gauze moistened with normal saline over a wound or packed into a wound cavity. Extra layer of gauze or other dry dressing is placed over the moistened gauze. It is a traditional dressing that is frequently used despite evidence to the contrary. Delay wound healing, often attributed to frequent dressing changes and the drying out of the gauze within hours, which achieves a non-selective mechanical debridement when removed. It is used under the perception that gauze is a one-size-fits-all dressing, and it's also a readily available and low-cost dressing. Let's see what we found during our literature review. The following statement by Wadash summarizes all the articles and studies we reviewed. The use of wet to dry dressing is considered a substandard practice. I'm not going to review all the studies and articles. I will make this presentation available and you can refer back to these slides. So the review of literature pointed out to 5 critical issues, and the first one is infection control and cross-contamination. Some of the studies mentioned that the removal of the gauze from the wound bed released bacteria into the surrounding atmosphere, thereby contributing to the airborne contamination. A in vitro study showed that bacteria could penetrate up to 64 layers of gauze. And then gauze dressings increases the risk of infection and cross-contamination because they do not present any physical barrier to the entry of bacteria into the wound bed. The second issue we identify is pain during dressing change. And this is due mostly because a lot of these dressings, they have to be changed 2 to 4 times a day. and this can cause substantial discomfort and pain to the patient, poor patient compliance or adherence to the treatment also. The third issue we identify is non-selective in removing tissue. And as I mentioned earlier, wet to dry dressing, it is a non-selective in removing the healthy and the non-healthy tissue from the wound bed. The fourth critical issue we identify is delay in healing time. And this is because wet to dry dressing requires between 2 to 4 times daily changes, which lead to a drop in wound temperature, causing vasoconstriction and decreasing in blood perfusion, further drastically impairing the ability of oxygen to clear bacteria from the wound, leading to an increase in tissue infectability. Wet to dry dressing also prolongs the inflammatory phase of wound healing, counterproductive to all efforts to heal the wound. And the last issue we identify is cost effectiveness. Mechanical debridement was not clinically indicated in more than 78 cases in a retrospective chart review that examined admission orders for 202 randomly selected home care wound management with wet to dry dressing. And frequent use of wound not requiring mechanical debridement was also identified in a article review of literature on wet to dry dressing and reporting on related performance improvement projects. Let's review some essential factors that should influence the dressing choice relative to wound presentation. The principles of wound bed presentation include tissue debridement, inflammation, infection, moisture balance, and edge advancement. Other factors to consider are risk of contamination, potential injury to deeper structure, underlying nerve or tissue damage, presence of perfusion deficits, presence of tissue edema, tetanus status, and amount of tissue loss. Wet to dry dressing is associated with cooling reduction in the wound tissue due to frequent changes. Tissue temperature in wounds with gauze dressing have been found to be between 77 degrees Fahrenheit to 80.6 degrees Fahrenheit. We identify two optimal conditions that promote wound healing. The first is optimal moist wound environment maximizes the biological process required for wound healing. A wet environment reduces pain, reduces scarring, activates collagen synthesis, facilitates and promotes keratocytes, migration over the wound surface, and supports the presence and function of nutrients, growth factors, and other soluble mediators in the wound microenvironment. The moist environment is also favorable for various topical treatments, as well as for tissue and cell transplantation. And moist wound bed facilitates autolytic debridement while controlling exudate. A second optimal conditions that we identify is concerns the constant temperature in the wound bed, which is necessary for optimal cellular activity to promote wound healing. It was found that temperature reduction below 98.6 Fahrenheit leads to delaying mitosis for up to 4 hours, reduces leukocyte activity including phagocytosis for up to 12 hours, and increases the risk of infection. It takes up to 4 hours for the wound bed to return to 98.6 degrees Fahrenheit post-dressing change. And if you take into account changing the dressing every about 4 times a day, you barely manage to reach this temperature until it's time to do another dressing change. The concept of moist wound healing was first introduced in 1960s by Dr. George Winter, which was the first to demonstrate in a Porchy model that wounds heal faster when kept moist, which makes this a significant shift in the wound care philosophy. By the 1990s, commercially available advanced wound care products began to emerge, offering a new option for clinicians. And entering the 21st century, tissue engineered therapies became available, further expanding the therapeutic landscape. However, despite these advancements, our understanding of the complex biological mechanisms and pathways involved in both normal and impaired wounds healing remain incomplete. During our studies, we found that randomized controlled trials have repeatedly demonstrated that wet-to-dry dressings are not appropriate in any healthcare settings. And some studies demonstrate that moist wounds heal 2 to 3 times faster than those that were allowed to dry out, such in the case with the wet-to-dry dressing. In the following slides, we're going to review some current wound dressings methods and therapies supported by evidence-based practice. Moist wound dressings can be divided into film, foams, hydrocolloids, hydrogels, alginates, and negative pressure wound therapies. In both retrospective and prospective clinical studies, rates were revealed to be higher in wounds dressed with gauze dressings than with hydrocolloids or transparent film dressings. This slide includes various types of dressings with their advantages and disadvantages. I'm not going to review all of them. I will point out only one in the slide because in the next slides I will cover some of them. So the one that I would like to point out is alginates. And this is a moderate, highly absorbent dressing, maintains a moist environment. And some of the disadvantages are that it's not suitable for dry wounds and may require secondary dressings. In this slide, we'll go over some of the dressings that promote an optimal moisture level, such as hydrogels, hydrocolloids, and polyurethane foam dressings. So the hydrogels, they are hydrophilic amorphous gels that regulates fluid exchange from the wound and can absorb or donate moisture to the wound. Hydrocolloids are opaque, occlusive wafers dressings that turn to gel upon contact with wound exudate and stay in place for 3 to 7 days. Polyurethane foam dressings such as Alevin, Lufoam, and Tile are indicated for acute such as surgical wounds and chronic wounds due to their higher ability to absorb moderate wounds exudate, maintain moisture. They are effective in thermal insulation and provide some cushioning. Another alternative method for wound management is vacuum-assisted closure negative pressure wound therapy. And some of the benefits are related to decreased morbidity, cost, duration of hospitalization, increased patient comfort, stabilizes the wound environment, reduces wound edema bacterial load, improves tissue perfusion, stimulates granulation tissue and angiogenesis, speeds up the healing, and improves the possibility for primary closure of the wound without needing further plastic procedures. In a randomized controlled trial comparing vacuum-assisted closure therapy and conventional dressings on wound healing in the patient with a diabetic foot ulcer, it was concluded that vacuum-assisted closure therapy meaningfully reduces the time to complete wound healing by speeding up granulation tissue formation without any increase in the incidence of complications such as bleeding and infection. In a systematic review and network meta-analysis that included 25 randomized controlled studies containing data on moist dressing, such as hydrocolloids dressing, silver ion dressing, biological wound dressing, and polymeric membrane dressing, compared to sterile gauze dressings, such as the traditional gauze dressing, concluded that moist dressings were found to be more advantageous than the traditional dressings in terms of cure rate, healing time, and number of dressing changes required. More so, foam and hydrocolloid dressings were associated with a shortening of healing time. Let's recap. A wet-to-dry dressings achieves a non-selective tissue removal, thus accomplishing a mechanical debridement. There are multiple concerns when using a wet-to-dry dressing, such as infection control and cross-contamination, non-selective in removing tissue, pain during dressing change, delaying healing time, and increasing cost. There are two ideal conditions that promote wound healing. One is maintaining an optimal moist wound environment to maximize the biological processes for healing, and two, to maintain an appropriate and constant temperature into the wound bed necessary for optimal cellular activity. And three, evidence-based alternative dressings that maintain a moist wound environment are hydrogels, hydrocolloids, and polyurethane foam dressings. And for the visual learners, I made this slide here with wound dressings based on an exudate amount and dressing properties, such as the dry wound. You will want to choose a hydrogel or a collagen because they will release moisture. Some of the dressings that maintain a moist environment are polyurethane and non-adhesive foams. And some of the dressings that will absorb the exudate from a very wet wound will be hydrocolloids, calcium alginate, or a negative pressure system therapy. Please contact me or Lauren if you have any questions or concerns, and thank you for your attention. The remaining of the slides contain the references.